Good afternoon, everyone, and welcome to this collective conversation, which is organized by the Collective for the Political Determinants of Health. My name is Emma Sandvik Ling, and I'm a PhD at the University of Oslo, and I'm also a member of the Secretariat of the Collective. The Collective is dedicated to advancing research on how power constellations, institutions, interests, and ideological positions affect health within different political systems and cultures and at different levels of governance. The Collective Conversations event series aims to bring an original and critical lens to global health debates by discussing how the political determinants of health shape outcomes. This event is titled The Collapse of the NGO Model for Foreign Aid Post-USAID and features collective member James Pfeiffer. Just before we start, I have a few notes of housekeeping to go through. So as you might have noticed, this event is recorded, but only the first half, meaning up until the end of James's presentation. So the Q&A session will not be recorded. Audience members are welcome to ask questions, either by using the Q&A function and submitting written questions there, or by clicking raise hand and asking your question directly when called upon. The next collective conversation will be on the 17th of March, and more information about this will come soon. And if you wish to stay up to date about this and future events and other activities at the collective, please do sign up to our newsletter or follow us on LinkedIn, and I will post links to those in the chat shortly. I will now hand over to our chair for today, Robert Yates, who is also a member of the collective. Rob is a political health economist specializing in universal health coverage and progressive health financing. He's a visiting professor in practice at the London School of Economics and an honorary associate professor at the London School of Hygiene and Tropical Medicine. He was formerly the executive director of the Center for Universal Health at Chatham House and was previously a long-term consultant to the elders on their universal health program. He has special expertise in the political economy of UHC, with a focus on advising political leaders and government ministries on how to plan, finance, and implement national UHC reforms. So over to you, Rob.
Fantastic. Thank you so much, Emma, and greetings from chilly London, wherever you are in the world. It's great to be with friends, and especially given the dismal state of the world at the moment. Looking at, we were just chatting before coming online at the sort of demise of our entire sector, not just the health sector, but in international development, full stop. And so I think it's sort of very important to have events like this of the collective to sort of discuss the state of the world and what are we going to do about it. So I do hope in today's session that we're not just going to be all doom and gloom, sort of about the disasters befalling us, and that we might be looking to what we're going to do about this. But it is absolutely sort of fantastic that we have James with us today to discuss what clearly has been the complete collapse of the NGO model of health development in recent years. And I think we can sort of trace a lot of this back to the pandemic and coming out of the pandemic, where the collapse of the aid system, not only US aid, but the Australian aid, UK aid as well, sort of practically sort of disappeared when we saw the demise of our Department for International Development. So this has been happening all over the place at a frightening rate. And I'm sure we all have friends, perhaps even people on the call today, whose careers have been badly affected by this and are very worried about the future. But I say we're not going to be all doom and gloom today. James in particular is going to be talking about the situation about US aid and the United States. And I think James is going to talk to us for about 25 minutes, half an hour or so, and then we'll go into Q&A, please. And if people want to pose their questions, do it in the Q&A, or also you can raise your hands. If you can get your questions in as they come to you nice and early, that perhaps gives me a better opportunity to sort them a bit and sort of line them up, as opposed to it's like sort of flapping around when no one's asked any questions when James finished. So I'd be very grateful if you could put your questions in nice and early. So our speaker today, and I don't think we could have come up with a better speaker given his academic experience, but also frontline experience in NGOs. So James Pfeiffer is currently professor in the Department of Global Health in the School of Public Health at the University of Washington, Seattle, with a joint appointment in the Department of Anthropology. Dr. Pfeiffer was also Executive Director of Health Alliance International, HAI, for 10 years, where he oversaw public sector health system strengthening projects in Mozambique, Côte d'Ivoire, and Timor-Leste. Now, in 2022, HIA turned over all its grants and projects to local NGOs that had helped launch in its 3 focal countries. But HIA continues to this day in Seattle and the University of Washington as Health Advocacy International. So Dr. Pfeiffer earned his PhD in anthropology and his MPH at the University of California, Los Angeles. So I said, I can't think of anyone better to talk about this topic than James. So over to you, James, and we look forward to hearing your thoughts. Thank you.
Wow. Well, thank you so much, Rob, for that really kind introduction. And thank you for taking the time to kind of be the conversation mediator. I want to thank Emma and Caterini from the collective for organizing the talk. What a great opportunity and so much to talk about. So really glad to have this opportunity. I'm going to try to jump right in. I have to make sure I can share my slides. So let me do that now. And make sure this is working right. Can you see that, Robert? Does that look
perfect?
All right. Wonderful. Fantastic. So first of all, before we start, I just want to thank all the Norwegians who are in their cabins skiing. That this week is in Norway. Apparently, you get a whole week. Everybody gets a week off in the middle of winter just to go out and play. And like that, what a fantastic thing that is. So thank you for any of those who've taken time to zoom in during your break. So as Robert said, I'm focusing on this collapse of the NGO model for foreign aid, and I'm going to try somehow to come out with a little positive spin on what's happening. In every crisis, there's an opportunity, as the cliche goes. So just a little bit of background on myself. As Robert mentioned, I work with Health Alliance International really for about almost 30 years. I lived in Mozambique for a number of years, was the executive director based in Seattle, but traveled back and forth to Mozambique, several times a year, working on our projects there, and also in Côte d'Ivoire and Timor-Leste. This is a picture of 3 frontline maternal child health nurses in the Beira rural hospital. Beira is one of the second largest city in Mozambique along the coast, and just sort of wanted to start what are we talking about here? We're talking about primary health care in national public health sector systems. These are mothers coming in with their kids for well child visits, and these maternal child health nurses are the real heroes of global health, in my opinion, all around the world doing 80% of the care. They are understaffed, underpaid, and I'm going to talk about that and how do we get to universal health care. So it's great to have Rob here to help us talk about UHC going forward. But that's my background, is spending many years on public sector strengthening work. Just quickly, a snapshot, and I'm going to show this because I want to talk a bit about it when we go forward. Mozambique's public sector primary healthcare system, which was built after independence in 1975, has pushing 2,000 health facilities all around the country. Basic rural health posts, rural health centers. But you'll notice its physicians and nurses per 1,000 numbers are far below the WHO basic standard. We need 10 times as many physicians to get to the basic 1 physician out of 1,000. They have APAs, are actually community health workers. They're very proud of this program that started way back in the late 70s, and they've been training more and more of those. But I want to just point out percentage of the population with access to health services less than 30 minutes by foot is only 68%. So highlighting that Mozambique has done an amazing job of getting a primary healthcare system out there, but they are underfunded, understaffed, and need more. And this kind of lays a foundation of many of the things I'm going to talk about going forward. So what's the problem? I think, imagine pretty much everyone who's zoomed in here knows what's happening here is the end of USAID specifically, but also cuts to other U.S. funding, but especially USAID is calamitous. It's tragic. It's horrific. It was so much funding coming from USAID for programs around the world that this is an article in Nature that came out back in April that estimated up to 25 million deaths over 10 years that could happen if the U.S. ends its global health funding. So people have been trying to model it. Over here, as I kind of squeeze it in here, is a new article that just came out in February, The Lancet Global Health, that tries to estimate the loss of ODA more generally, not just USAID, but the declines in European financing. Excuse me. That forecasting up to 10 million deaths or more. So what we know, it's bad. It's already bad. We're hearing reports. People are gathering data on what's happening as programs and NGOs have closed all across the global south, but especially sub-Saharan Africa. Just a graph from the Kaiser Family Foundation. KFF has a tracker for funding, and you can see the severe decline from 24 to 25 in USAID funding, and I think that's going to basically go to zero or close to zero by 2026. So it's severe, and you can see, it was $7 billion a year, and now down to less than $3 billion. It's going to go down even further. So the argument I'm making here is that one of the reasons why it's so catastrophic, the closure of AID, is that so much of the funding was actually channeled to non-governmental organizations, and mostly really American NGOs and contractors, some for-profit contractors. And what that meant was that funding was not going in generally, because I saw it on the ground, my experience in the countries where I worked, most USAID funding was going to NGOs that were not really focusing on long-term capacity building and strengthening of the local public health services, the public sector services. Our organization was committed to trying to do that. We tried to be different from other NGOs. Sometimes we succeeded, sometimes we didn't. Where all the work we did was following their priorities of the Ministry of Health and the national health systems in the countries where we worked, trying to strengthen the provision of public sector healthcare. But many NGOs, the vast majority of NGOs, were not doing that, right? They're sort of setting up shop, doing their own thing. And what the argument I'm making partly here is that model has led to the end of USAID funding has been that much more catastrophic, because rather than the NGOs having handed over their work in a really well organized way to local institutions so they could continue it because their capacity was built, those NGOs, when they closed up shop, everything just disappeared. And we're seeing this all across the global south. So it was the very model of aid that USAID was using has made the closure that much worse. And so this is kind of the point of sort of where do we go from here. So this is some basic numbers from the Congressional Research Service. If you look at from 2013 to 2022, where did USAID funding go? Well, 52% at least went to non-governmental organizations, pretty dramatic. And 34% to organizations like Gavi and WHO and UN or agencies and that kind of thing. So all of that has also gone away. So that's damaging in itself. But the largest chunk was actually going to American organizations. Then we look at what kinds of organizations by NGO type. So 47% to nonprofits, but then there's all these for-profit enterprises like Chemonics and ABT Associates and others, which we sometimes call the pejoratively call the Beltway Bandits, and some faith-based organizations. But you can see that these are the organizations that were doing so much of AID's work on the ground. So you may already know this, but it's always good to kind of look at a graph to show how insane the growth of international NGOs has been over the last several decades, really taking off, mainly really in the 90s. One estimate is that there's as many as 55,000 international NGOs now. You go back into the 70s and it was far fewer. You have different estimates of these, but just to make the point, there's lots of NGOs. And why are there so many NGOs? It's in part because organizations and donors like USAID started shifting their funding to NGOs, especially in the late 80s and 90s. We'll talk about why they did that. So that's where the gravy train was, and it led to many, many NGOs being formed to tap into those resource flows. So just so you have a sense of it, these are NGOs obligated more than $1 billion from 2013 to 2022. These are American organizations got funding from USAID and PEPFAR to some extent. And notice, Catholic Relief Services, $4 billion, Chemonics, $4 billion over this period. So we're talking about billions and billions of dollars flowing to American organizations and contractors. This is a scientific rendering of what this aid model looks like. This might be the image that sticks in your head. Here's the donors up here, USAID, maybe Bill Gates, I don't know who else. NGO staff in the US, like our HAI staff here in Seattle, we get a big cut of the money, and then that money goes to our NGO staff on our infrastructure in country. They get a lot. And then maybe a trickle goes to our National Health Service colleagues, who are the ones actually doing the work, treating people and taking care of business. And then, of course, patients at the end get the least of anything. So what I'm kind of saying is maybe we need to think about how donors go straight here, maybe in the future skip over some of this. So we'll come back to that. Booz and Walt famously called the NGO world an unruly melange. I like that term. And here's some of the key shortcomings. We often, as NGOs, parachuted in and set up shop at local district levels, often creating services and programs that were parallel to national health services, right? Not integrated. We're doing our own thing. We often offered only perfunctory coordination with public sector national health services. I'm telling you, this is the norm, right? Ministries of health often not knowing what NGOs were doing in their own sector. Often develop parallel monitoring and evaluation systems and data reporting. A big problem. Gathering and understanding and analyzing data is critical to running a health system. And many NGOs had their own systems. We'll talk about what PEPFAR did with data systems as a parallel system. They often poached National Health Service staff away from public services with high salaries, contributing to what we call internal brain drain, right? So NGOs actually stealing people from National Health Services. We often use norms and procedures that differed from the national health system, right? If we were actually providing services, we might provide them in a very different way, which caused lots of problems. Generally, it created the NGO model, in our experience in the countries where we worked, an uncoordinated, fragmented, inefficient health sector landscape where local health officials were often sidelined. Big problem. And what we really failed to do was to build long-term capacity in local institutions. This is really a sustainability issue, right? And we've just demonstrated to us in the most tragic way how unsustainable so much of this work actually was. We often when our grants ended, we'd have, say, a 3 to 5 year grant. It ends, we just pack up and we leave. And what's left behind? And I can tell you just dozens and dozens of examples of this, of AID funded work that ended this way. And now we're seeing on a grand scale, the whole house of cards comes down. So now I'm going to talk a bit about PEPFAR. And I don't know, most of you probably know what it is. PEPFAR is the President's Emergency Plan for AIDS Relief, right? Initiated by George Bush, a Republican. It always had bipartisan support. And so we jokingly called it, some of us anyway, a new scramble for Africa, right? This is an image of the Berlin Conference, of course, in the 1880s, in which Europe divided up Africa to colonize it. There was a sense that many of the NGOs, and here's HAI, my own group here, were kind of participating in a carving up of Africa without any Africans in the room. Now, the reason why I bring this up is we had a moment in Mozambique back in about 2007, 2008, when I and a colleague from HAI became the main PEPFAR implementing partner for the center of Mozambique for three big provinces, which are really kind of the epicenter of the AIDS epidemic at that time. And we were meeting with AID in the big fancy AID building in Maputo with other NGOs, Japigo, ICAP, ABT, and others around FHI 360, talking about how we're dividing up the country. So we have the AID folks, we have all of us, mostly Americans and Europeans, running these things. There's not a Mozambican in the room. There's nobody in the Ministry of Health in the room. And my friend and I, my colleague and I, we walked out of it going, wow, that was just like the Berlin conference. This is the new scramble. And we're all competing with each other for access to geographic locations in the country. So PEPFAR was an interesting moment. Now, I want to be real clear. PEPFAR has done some really important stuff. The funding was hugely important for getting people onto AIDS treatment. It has absolutely saved millions of lives. So I want to speak out in favor of PEPFAR and hopefully PEPFAR continuing. That's my opinion. But also, and this is shared by many of my colleagues, it could have done even more, right? And so what we see, here's an example of how PEPFAR money was actually spent. It didn't go into sustaining actual public sector health systems where AIDS treatment was happening. So this is just one graph that's been published out there from the start of PEPFAR up till 2010. You can see that generally the great majority of PEPFAR funding is going to NGOs, that's the green bar, for-profit organizations. So that's like ABT and these other contractors that act like NGOs. So you can kind of put them in the NGO category. And then it has academia here, and that includes organizations, NGOs that are linked to universities, like ICAP is part of Columbia University, for example. Partners in Health is part of Harvard or connected to Harvard. So a mere by 2010, only 11% was going to local governments, and even that was going to very verticalized programs, not to recurrent expenditures to building a health system. So huge amounts of money going into the health sector, but not going into the public sector system itself. So in 2016, just as an example, PEPFAR in Mozambique, the Ministry of Health budget, about 462 million. PEPFAR was just PEPFAR alone was almost equivalent to the entire Ministry of Health budget, and 90% of this is going to American organizations. Then there's other HIV donors, and all of this is HIV money. The Ministry of Health is dealing with, of course, everything else that's going on in health. And you get a real sense of the incredible imbalance and how much money was going to, say, American doctors, American staff, having salaries of up to $300,000 a year with, housing and cars and all that kind of stuff. How much money was actually going to American NGOs and contractors out of PEPFAR rather than long-term sustained building of local health systems. This is just an example of, this is back in 2016, the fifth Feira das ONGs, the NGO fair, working in health and HIV. And you can see this whole constellation. This is just some of the NGOs active in Mozambique. I mean, this is the unruly melange. There's HAI, our little logo, FHI. This is so typical of many countries across Africa, getting billions of dollars over time flowing to these organizations. One of the things we did a study, HAI, back in 2000, published in 2013. What we looked at how local doctors were being pulled away from the National Health Service, and where were they going? And about 75 went to NGOs during this period. That's a lot of doctors in Mozambique. And about 40%, close to half, were going to PEPFAR-supported organizations. And this was such a concerning outcome that this was actually highlighted in Hillary Clinton's PEPFAR End of AIDS report that came out a couple years later. And they said, we shouldn't be doing this. We're weakening health systems when we steal doctors. But this practice still continued. Again, these are the same graph. Just to remind you, these are much of this money that went to these NGOs was actually PEPFAR funding. So we're talking billions and billions of dollars going to American organizations. So what were PEPFAR implementing partners supposed to be doing, and what didn't they do? So in a nutshell, they did a lot of things, but really importantly, providing training to National Health Service workers. That's important, right? That's good for sustainability. Often set up supply chains for medication materials. This is a big piece of what they support. How do you get all the aids, drugs, and other commodities flowing? But they often set up parallel PEPFAR data systems. So in Mozambique, there was a whole PEPFAR data system that was completely disconnected from the Ministry of Health data system and a source of constant frustration for the local institutions. We conducted implementation science studies to improve service delivery. Not a bad thing, it's a worthwhile thing. Provide funding for local community-based organizations and community health workers to support patients, right? So a lot of funding going to community health workers. Say, well, that's a good thing too. But what did we not do enough of? We didn't provide long-term support for training and expanding the health workforce. We were prohibited from actually contributing to the payroll to expand the health workforce. And the health workforce is even after 20 years of billions of dollars of PEPFAR funding, the Mozambique, for example, the Mozambique National Health Service health workforce is still miles away from even the minimum it should be. We weren't allowed to spend money extending the health system infrastructure. As we said, only 68% of people have access to a health service under 30 minutes by foot. We should be building more health posts, getting further out there, but PEPFAR money wasn't allowed to be spent on that. Build logistics systems that should be handed over to and managed by public sector services. So I'm going to talk a bit about that in a second, how devastating that has been when those NGOs closed. We should have been strengthening Ministry of Health information systems. I had an interesting meeting with the provincial director of Sofala province, who was a terrific manager. And I would report to her as HAI that's supporting their health sector. And she would say, hey, we really appreciate all of HAI's work. Thank you for all you're doing. But you know what I really need? I really need some IT specialists. I need somebody to help build our data systems to get the viruses out of our computers. I need a logistician. I need an accountant. I need human resources people. No NGOs are doing any of that kind of work. And so this is what I really need to do to manage my work here. Strengthen Ministry of Health information systems, readily share PEPFAR data. We didn't do that. We should have been building operations, research, and implementation science capacity in the Ministry of Health and the National Health Services. NGOs didn't do that. They would get their NIH-funded projects or other kinds of stuff, do their projects, do their pilot things, maybe include some Mozambican scientists on it, but not really building the local capacity to be able to do this critical kind of research. How do you improve service delivery? So this is a chart from an article that came out in the Washington Post back in September, that a really nice piece of reporting, if you track it down, that basically said this is what's happening with the closure of AID, is that pediatric antiretroviral medications are just not getting delivered or getting hugely delayed, and they sort of document this. And we know that in Mozambique, as an example, there was an NGO called Village Reach, based right here in Seattle, was funded by USAID to manage all of what they call the last mile delivery of antiretroviral drugs to the health system, to the different health posts where millions of people across the country are getting their HIV drugs. Stunningly, when Village Reach closed because AID ended, there was no way to get the drugs out to the health posts. So we heard from our Ministry of Health colleagues going, oh my God, we're in a panic. This is terrible. They went for about 6 months, and interestingly enough, Bill Gates, the Gates Foundation, stepped in and started funding Village Reach to do this. But why was it that the Ministry of Health didn't have their own logistics system, perhaps with NGOs support, but this is the way AID has worked, right? Having these NGOs and contractors actually doing this work. So this is what was happening across all of these countries in Africa, and beginning to document child deaths as a result of not getting pediatric ARVs on time. So having said all of that, the closure of AID projects around the world has been catastrophic because they just, clinics have closed, logistics systems have closed, programs have closed, all kinds of key things. And we're just beginning to document the human cost of this, but it's going to be huge. But the point I would want to make is that had we been doing our funding differently, it still would have been bad, but it wouldn't have been as bad. We would have been building local institutional ability to manage this in a sustainable way. And what we've just seen is a demonstration of how unsustainable this model truly was. So where do we go from here? So here's some bad news. Marco Rubio, who is our current U.S. Secretary of State, has issued what they call the America First Global Health Strategy. You may have heard something about this, but it's kind of, what are we going to do now? Now that we're closing USAID and all this other stuff, PEPFAR funding, interestingly enough, is going to continue. And PEPFAR funding actually got channeled through USAID to be implemented, right? So without USAID, what's PEPFAR going to do? We're not really sure yet. It's going to be reduced substantially, but still going to be there. There is substantial Republican support for PEPFAR. It was a PEPFAR initiative. Marco Rubio has been very clear, even under Trump, that he says, I'm in favor of PEPFAR. I think it's a good thing. So that's a little sliver of good news that won't totally go away. It's going to go down, but they're now emphasizing bilateral compacts, what they call compacts, 5-year MOUs with individual countries. And it's kind of weird. They're saying we're actually going to give the money to individual to countries in a way that almost sounds like something people like myself would think, oh, well, that's a good thing. But and NGOs are left out. But their goal is to reduce dependency and increase what they call co-investment. And what's fascinating about this America First Global Health Strategy is they have exactly the critique of NGOs that I just gave. They said it was wasteful, it wasn't good, all this money was going back in the pockets of Americans, this was inefficient use of money. We're all thinking, people in my colleagues, where do they get these lines? How odd that they're stealing our argument, which kind of seems like they are, to then use it against what we think would be the right thing to do. But that's what's happening now. So part of what they state in this is that these bilateral compacts are likely going to turn into things where the government is being pressured to subcontract to American businesses of some kind. We're waiting to see where this goes. We don't know exactly what's going to happen, but it's going to be very transactional. They're talking now about trade, not aid, whatever that means. They're talking about promoting the private sector and, very importantly, be very wary. I'm sure you're not surprised by this, but promoting emerging markets for American pharmaceuticals and private healthcare companies. Deeply, deeply troubling, I think, to me anyway, and I'm sure to many people on this call. So, things are changing so quickly in this our current Trump regime. You never know what's going to happen next, but this is what's on paper. This is what they're telling us. I want to make this sort of obvious point, but one that doesn't get mentioned enough. In the midst of all the cuts to USAID, we're in one of the worst moments of the international debt crisis, really, of the last 40 years, is what people are telling us. Most countries in sub-Saharan Africa are deeply, deeply in debt crisis, are under the IMF boot for austerity. And so how are they supposed to co-invest when they are spending more on debt repayment than they are in healthcare? So this is so fundamental to all of this. And if we go all the way back to why did USAID channel its funding to NGOs, it was in many ways ideologically driven, right? It was the era of small government. We want to be supporting so-called civil society. Big government is not good. And this is kind of the consequence. And then all of this was happening during the structural adjustment period, during the debt and austerity period. So rather than funding national health services that are doing all the really hard work, all this money was going to private non-governmental organizations, kind of part of the privatization view overall. So we have to think about where do we go with the debt crisis if we're going to be thinking about how we recover from what's just happened. Pithy quote from Ivo Garrido, who was the Minister of Health from 2005 to 2010. We worked with him quite a bit. He once told us when we asked him, how do you go to the Ministry of Finance to, ask for more funding to expand your health workforce? And he was very frustrated. And he said, there are no ministries of finance in Africa. There's just the IMF. Every time he would go in to say, I need more money for AIDS, the treatment scale up, I need more workforce, they would say, nope, there's the IMF guy would be sitting right next to the Minister of Finance. Universal health coverage, this is Rob's, and I'll be finishing up right away here. This is Rob's territory. WHO tells us that we need 18 million additional health workers by 2030. The minimum standard, there's some controversy around this, but one physician per 1,000 to support UHC. And just a collection of numbers here that most of sub-Saharan Africa is miles away from even the minimum standard, as Rob Yates can tell us, from even getting close there. So very importantly to point out that over these 20 years of PEPFAR funding, but even more years of NGO funding, we've barely budged on the workforce ratio getting better. Billions of dollars floating to NGOs while local national health service budgets were severely restricted. There's something wrong with this picture, right? That's the basic point I kind of want to leave here. So where do we go from here? I'll finish up on this. Demand restoration of aid, support local national health sector leadership. I think this is absolutely critical, right? We need to be listening to the countries where we work. What do they need? What do they want? Is the sector-wide approach to planning or the common fund the best approach? That gets a little policy wonky, but we could talk about that. We need to call for debt cancellation and debt forgiveness. I think simultaneously reject austerity and privatization and support increases in public investment in health and the social sector. I know these are all fantasies and dreams. I'm just putting them out there in the current environment. Focus future aid flows on long-term building of public sector institutions. And but what role for NGOs? I actually believe there is a really critical role for NGOs, but it's not the one they've mostly been playing recently. So I'd love to talk about people's thoughts there. There is growing rebellion around Africa against IMF austerity policies. This is a photograph from recent demonstrations in Kenya. I'll finish with a quote from Ivo Garrido. Health systems are a country's mechanism for taking care of its people. If you want to help strengthen the national health service. Seems like something we don't need to repeat over and over again, but in the NGO world, you would be amazed how many of us were not doing this over many years, and now we've seen the consequences. So, obrigado, as they say in Portuguese in Mozambique. This is a photograph of Susandenga Health Center in Manica Province, where women are waiting, huge demand for these services and an overworked, underpaid health workforce that needs all the help they can get.